Szanowni Państwo, witamy Państwa po przerwie. Jeżeli mówimy o technologiach, nie może zabraknąć tematu sztucznej inteligencji, który był ostatnio odmieniany przez przypadki chyba w każdy możliwy sposób. Zapraszam na scenę naszą następną gospodynię tak naprawdę panelu, panią profesor Katarzynę Kolasę.
Dziękuję bardzo serdecznie. Dziękuję bardzo za możliwość udziału w dzisiejszym bardzo ważnym spotkaniu. Mamy do czynienia nie tylko z rosnącym poziomem innowacji w systemie ochrony zdrowia i mamy nadzieję, że również z intensywnie nadążającym za nim poziomem wdrożeń innowacji w ochronie zdrowia, szczególnie tych opartych na sztucznej inteligencji. Dlatego strasznie miło mi jest zaprosić Państwa z krótkim przemówieniem do nas gościa, dzięki któremu angażuje się w wiele projektów badawczych. Pan poseł Grzegorz Napieralski jest przewodniczącym podkomisji do spraw algorytmów, ale również wiceprzewodniczącym Komisji do spraw innowacji i cyfryzacji. I chciałabym, żeby troszeczkę wprowadził nas w zagadnienia tak dla nas ważne w kontekście innowacyjności w ochronie zdrowia, jakim są osiągnięcia, ale również te pomysły, jakie mamy na innowacyjność w Polsce i co za tym możemy zrobić w systemie ochrony zdrowia, żeby przyspieszyć to, co powiedziałam na początku, wdrażanie różnych możliwych technologii opartych na sztucznej inteligencji. Więc bardzo dziękujemy, panie Grzegorzu, że jest pan z nami i zapraszamy do udziału w naszym spotkaniu.
Dziękuję bardzo za zaproszenie, pani profesor. Szanowni Państwo, bardzo dziękuję za to, że mogę być z wami, chociaż wirtualnie, ale musicie mi wybaczyć, bo teraz trwa kampania wyborcza i no niestety musimy być w okręgu wyborczym, walczyć o głosy. Ale niemniej to spotkanie, które organizuje pani profesor, czy organizuje uczelnia, organizujecie, jest czymś dla mnie bardzo ważnym. Chciałem na samym początku na ręce pani profesor Kolasy złożyć serdeczne podziękowania, bo to tak naprawdę dzięki niej temat dotyczący sztucznej inteligencji, czy właśnie innowacji w systemie ochrony zdrowia trafił pod obrady i nie tylko pod komisję, ale również Komisji Cyfryzacji, Innowacyjności i Nowoczesnych Technologii. My zdajemy sobie sprawę, że tak samo jak 10 lat temu, no już prawie 13 lat temu, 13 lat temu, powstawała Komisja Innowacyjności i Nowoczesnych Technologii w polskim parlamencie, to jeszcze o sztucznej inteligencji mowy nie było. O algorytmach również, znaczy funkcjonowały te oczywiście terminy, natomiast byliśmy odlegli tak naprawdę od decyzji w tej sprawie. W ogóle innowacje, cyfryzacja to jeszcze były tematy, które w naszym życiu politycznym czy w ogóle społecznym nie były tak obecne, jak są dziś. Jesteśmy 13 lat później od powstania tej komisji. Wiemy dokładnie, że dziś algorytmy są obecne w całym naszym życiu, że sztuczna inteligencja prędzej czy później będzie odgrywała jedną z najważniejszych ról w naszym życiu, w życiu każdego człowieka. Co teraz powinniśmy zrobić i na co powinniśmy tak naprawdę zwracać uwagę? Sztuczna inteligencja myślę, że jest potrzebna w systemie ochrony zdrowia. Ona się już znalazła i będzie coraz bardziej zajmować poczytne miejsce w tym systemie. Patrzymy na sztuczną inteligencję jako na coś, co jest pozytywne, dobre, nowoczesne, coś, co ma nam pomóc. Ale wiemy też dokładnie, że sztuczna inteligencja, której nie okiełznamy merytorycznie w ramy prawne, też może stanowić zagrożenie. Dla nas, polityków, parlamentarzystów, kwestią najważniejszą jest oczywiście z jednej strony pacjentka i pacjent, z drugiej strony lekarz, lekarka, czy pracownik medyczny, czy pracownik niemedyczny. I wszystko, co dzieje się tak naprawdę za pomocą sztucznej inteligencji, musi przede wszystkim pomagać tym ludziom, ale stwarzać również bezpieczeństwo. Co możemy zrobić, bo to pytanie też padło z ust pani profesor, co powinno się wydarzyć. Myślę, że w przyszłej kadencji, no bo w tej kadencji już nic nie zdążymy zrobić, w przyszłej kadencji temat sztucznej inteligencji nie powinien być już tylko w pracach podkomisji. To powinien być element tak naprawdę pracy Komisji Stałej Polskiego Parlamentu. Wiemy dokładnie, że w Unii Europejskiej został przyjęty specjalny akt dotyczący sztucznej inteligencji, który zawiera bardzo wiele katalogów, bardzo wiele spraw, jest bardzo szczegółowy i to też musi znaleźć się w przepisach prawa w Polsce. Odrębną sprawą, to o czym wy dzisiaj rozmawiacie, o czym dyskutujecie, jest kwestia nowych technologii, innowacji, algorytmów, ale również sztucznej inteligencji w systemie ochrony zdrowia. I tak naprawdę dziś musimy sobie zadać pytanie, co zrobić, aby po pierwsze ułatwić dzisiaj każdemu podmiotowi, w każdym miejscu, gdzie leczymy i pomagamy tak naprawdę Polkom i Polakom, aby zachęcać do tego, żeby nowe technologie wkraczały i były tam obecne. Co zrobić, aby w szpitalach, w przychodniach, w specjalistycznych przychodniach, by te rozwiązania się znalazły, jak znaleźć na to pieniądze, ile tych pieniędzy powinno być, no i jak napisać prawo, żeby nie okazało się, że gdzieś popełniliśmy błąd i sztuczna inteligencja staje się być może wrogiem, albo może czymś, co wymknęło nam się spod kontroli, bo na to musimy absolutnie zwracać uwagę. Ta dyskusja o sztucznej inteligencji nie tylko w systemie ochrony zdrowia trwa już na całym świecie, powstają specjalne fundacje, think tanki, ale też firmy, przecież duże giganty informatyczne również dzisiaj prowadzą na ten temat badania. Każdy wie, że bez sztucznej inteligencji świat się dalej nie będzie rozwijał, ale każdy też wie, że ona musi służyć nam, ludziom, a nie być sama dla siebie. Stąd myślę, że ważne, aby ta współpraca, którą dzięki pani profesor udało się nawiązać z Akademią Leona Koźmińskiego, z Izbą Lekarską, z poszczególnymi profesorami, naukowcami, którzy mają dużą wiedzę, ale również z praktykami, którzy pojawiają się w polskim parlamencie i nam pomagają, że tą współpracę trzeba kontynuować. To mówiłem na wcześniejszej konferencji, powtórzę to jeszcze raz, bo uważam, że to jest rzecz chyba najważniejsza i najistotniejsza. To, że my, mówię o politycy, my posłowie, my posłanki, nie jesteśmy w stanie tak naprawdę bez merytorycznego wsparcia tego zrobić. Tym merytorycznym wsparciem jesteście wy. To wy tak naprawdę możecie nam pomóc, możecie nam pokazać, jak to powinno zostać uregulowane prawnie, tak aby to nie blokowało rozwoju sztucznej inteligencji, nie blokowało rozwoju, ale było czymś, co pomaga tak naprawdę i my musimy mieć tą świadomość jako politycy, że mamy też tą pomoc zapewnioną od was. Bez pomocy naukowców, bez pomocy biznesu, który pracuje nad różnymi rozwiązaniami, tego nam się nie uda szybko rozwiązać. Oczywiście możemy pracować, ale po co iść naokoło, skoro można pójść drogą na skróty. Stąd to, co wy robicie dziś, co robiliście wczoraj, jest, myślę, dla nas bardzo ważne. Te badania, które zespół pani profesor przeprowadził, to jak współpracujecie z Naczelną Izbą Lekarską, jak tak naprawdę świat nauki spotyka się ze światem tak naprawdę praktyki, jeżeli chodzi o system ochrony zdrowia, to dziś dla nas, polityków, będzie bardzo istotny, będzie bardzo ważny. Mam nadzieję na taką współpracę. Mam nadzieję, że będziemy mieli okazję, jeżeli oczywiście wyborcy dadzą werdykt pozytywny, spotkać się w przyszłej kadencji i na taką współpracę bardzo serdecznie liczę i myślę, że jeżeli będzie zgoda po waszej stronie, to ona będzie jeszcze bardziej owocna, jeszcze bardziej głęboka. Myślę też dlatego, że do tej pory patrzyliśmy na algorytmy, mimo że podkomisja trwa i praca trwa 4 lat, że patrzyliśmy na algorytmy i na sztuczną inteligencję trochę z przymrużeniem oka. Trochę patrzyliśmy na to jak na film science fiction, który pokazuje nam nowe odsłony osiągnięć innowacyjnych. Ale wydaje mi się, że już ten czas minął, że jednak wszystkie elity polityczne zauważyły, że sztuczna inteligencja jest już, tak? Już jest wśród nas, to już się rozwija, ona się uczy, ona zaczyna funkcjonować, ona bywa w różnych miejscach i od nas tylko zależy, jak mądrze ją pokierujemy, jak mądrze będziemy ją wykorzystywali. Bardzo jeszcze raz dziękuję za to zaproszenie. Jeszcze raz bardzo dziękuję pani profesor za owocną współpracę w tej kadencji i mam nadzieję, że w przyszłej kadencji również będziemy wspólnie współpracować. Dziękuję bardzo i życzę wszystkiego najlepszego w tych obradach.
Bardzo dziękujemy, panie pośle. Bardzo miło nam jest gościć. Nie ukrywam, że dzięki w tej współpracy do tej pory osiągnęliśmy już pewne sukcesy. Badaliśmy preferencje Polaków względem zastosowania sztucznej inteligencji w Polsce, w polskim systemie ochrony zdrowia i prowadzimy właśnie badania wśród personelu medycznego na temat ich preferencji w stosunku do kryteriów oceny sztucznej inteligencji w ochronie zdrowia. Dlatego wszystkich, którzy nas widzą, słuchają, serdecznie zapraszam do udziału w tym badaniu ankietowym prowadzonym przez moją doktorantkę. Teraz pozwolę sobie przejść na język angielski, ponieważ mamy speakerów ze świata, którzy dołączą do nas online po to, żeby opowiedzieć, jak wygląda stan na dziś zastosowania sztucznej inteligencji w przepisach, ale również w systemie finansowania świadczeń zdrowotnych. I po pierwsze chciałam zaprosić Axela Mühlbacher. Axel Mühlbacher was Health Economics and Healthcare Management Professor from Hochschule Neubrandenburg from Berlin. I hope, Axel, you are already with us. Axel Mühlbacher is health economist by training and have done a lot of research in studying attitudes towards preferences in healthcare system. Recently has been engaged in a number of projects related to digital health solutions. And that's why I think his contribution to our discussion is extremely important from two standpoints. One is the German healthcare system, who is more advanced than ours in terms of the development of a legal framework for digital solution implementation, as well as he's engaged in a number of projects related to digital health assessment from European standpoint. So I hope that Axel is already with us and I can give him the floor for a short introduction.
Yes, hello, I'm here. Thank you very much for your invitation. I'm very honored and humbled to present. Hopefully I can make a contribution, because the last words I just heard is that Germany just might do such a great job, which in a lot of perspectives, I don't think we're moving forward as fast as we could in evaluating these huge chances we have. But I'm going to start my presentations, which tries to link the activities of a value assessment in societal preferences, and I want to show you the benefits and risks of introducing AI to healthcare. I very much like the invitation of Katarzynę, and therefore I just wrote these two presentations of the last 2 days. I wrote a little article on LinkedIn. You have a QR code, which hopefully you can use your phones to just get direct access to the written version of this presentation, which is much longer and goes into more detail of what I'm saying, and maybe explains in deeper with deeper thoughts what I mean. The key learnings we had over time, and I have to apologize in advance because I'm an economist, I'm not a clinician, and I'm not an AI or software or IT expert. I'm solely an economist thinking about the utility and benefits, especially benefit assessment from a citizen or patient point. But even we as economists learn that AI has a huge potential in healthcare, and it's going to change the world. And we all see how it can change the world using AI, like ChatGPT and other forms. But we also have the discussion of benefits and risks. And your conference is greatly planned because yesterday Elon Musk, Zuckerberg, and 30 CEOs of the largest IT companies met at Capitol Hill discussing the pros and cons of AI, asking for a referee, first time asking the state to jump in and regulate the efforts which are done in this vast field. So we have to take a look at the benefits and risks. If we look at benefits and risks, it's always about the net benefit principle. It's always about looking how much do we have to give and what's the risk, or how high is the risk to being harmed. And that leads to two ways we can look at that. We are responsible for the things we do, but we also are responsible for the things we do not do. And that means we have to weigh, and I'm going to go into this in much more detail during the presentations. We need more citizen or societal input, which we call here societal preferences, when we implement these technologies. We have to understand the benefit-risk trade-offs, not only the expert panels, not only politicians, but I think everybody has to understand the pros and cons, and we have to weigh these pros and cons within the regulation. To break this down, it's easy. We got huge and promising benefits towards patient health, recovery of health, even stabilizing and more efficient healthcare systems. But we also have huge risks. There are side effects of certain treatments which are based on AI. We are surely facing system failures. And for example, we have to jump a hurdle which is related to the acceptance of patients towards these AI-driven systems. So basically, we're looking at the net benefit, which is the cumulative benefit minus the affiliated risk. So we both have to look at the benefits and risks. And why do we have to do this? Well, this is a easy cost-benefit plane. We got the x-axis where we have some sort of value, which we could call benefit of an AI system. And we got the y-axis where we either could print the cost or we could print the risk. And everything comes down to this northeast quadrant where we have more value, we're gaining value as a society or an individual, but we also have more costly or more riskier alternatives. So the question is, how much risk are we willing to accept in order to get the advantages, the value of these new AI systems? Or how much cost are we willing to spend or invest in order to get these values? And these are questions which cannot be answered by a singular person. These questions have to be answered by citizens. At least they have to be discussed. So I'm not asking for democratic voting, but I'm asking for a widely acceptance of these societal preferences, because once we spend money, that money's be gone. We could have done something else. If we do not spend the money on AI, we might forgo huge chances, and other countries might. Also, if we are not willing to take the risk, we might forgo chances. If we're willing to take the risk and we get harmed, that could be a huge harm to society. So we have to discuss the pros and cons, the benefits and risks. And the reason why this is such a tricky decision, the reason why politicians or expert panels might not be the sole well of these discussions or the sole parties who can make these decisions is because they will have overarching impact on our societies. We could do a type 1 error, which means we believe that we're going to benefit from AI, but we don't. It's too risky, it's too costly, and the benefits are not high enough, so we shouldn't invest and either take the risk. Or, which is something else, we wrongly forgo the chances of using AI because we think it's too risky, because we think it's too costly, and we would have large opportunity losses, which in fact will have large impacts on our societies and economies, because other countries will, other economies will use these technologies. So we have to make smart decisions. We have to be knowledgeable about the benefits and the risks, and we have to weigh these benefits and risks from a societal standpoint, and therefore we do need societal preferences. First and for all, and I'm starting from below these bullet points, first and for all, to get trust and cohesion, societies have to accept the pros and cons, have to accept the impact these technologies will have on our lives. Therefore, these assessments should be stakeholder focused. If we focus on the healthcare system, we do have to ask the patients if they're willing to accept certain treatments which are driven by AI. We have to ask the acceptance of doctors, of stakeholders, of payers. So we need a more broad value assessment. We have to balance the pros and cons, not only for all of the society, because we have these subgroups. So, for example, even if the society or these citizens are not willing to take the risk for certain AI or giving away their data, we might have subgroups, for example, like oncology patients, stage 4, very close to death, who do not care about their data, who are willing to give their data away in order to gain or even to impact future people's life. So we have to have a more granular view on these societal preferences. And we have to ask ourselves if it's enough only to ask experts or politicians, because they're going to use value judgments, which, by the way, may be more informed and maybe even smarter, but they're surely leading to a bias. So we have to include a discussion in the overall society. That's what I mean, ensured by societal preferences. In Germany, if we look at the legal framework, which is governing AI and big data, and I just picked a few. I didn't pick out the more generic laws, which also have impact on the implementation or integration of AI. But they're in the paper I published at LinkedIn. We do have the Medical Devices Act, which actually can be used to classify AI if it's used within the body, if it's used outside the body. That does have different risk groups. They need different quality assurances, and there are laws for certain surveillance. We do have the data protection and the patient rights, and also out of the German Ethics Committee wrote a paper, I think multiple, on transparency and accountability and human oversight of these new technologies, so that the process of introducing AI and big data into society or our healthcare system was closely monitored. And a lot of people did a lot of good things. We do have the Digital Healthcare Act, and I think that's something which might be interesting to take a look at. We do have the BfArM, which is an institute actually involved in the implementation of new technology. So that law was actually 4 or 5 years installed to recognize digital transformation. So I think that was a good start. And it actually tackled the interesting points, which means, how are these technologies being reimbursed? So how is a digital application, which is being used in healthcare, reimbursed through the statutory health insurance? And that was something very interesting. The Federal Institute, the BfArM, does have a DIGA fast track. There is an evaluation in form. They do call it benefit assessment. But the focus is on safety and reliability, which basically means their overall picture of how this is being assessed is a clinical trial, which often can or is not be done. But that's their sole interest, to see if it's clinically benefiting to the people who use that data. From an outsider view as an economist, that's not enough. Clinical data is necessary, but not sufficient to make these decisions. It's an important information, but it's not all of the information we need to make these overarching or wide-reaching decisions. So in critique, I would say we do not have a transparent framework to tackle the risks where we have the benefits and risk, which is in between scalability, quality. We have to find the middle ground between speed and accuracy of these systems and application, between data availability and privacy, which is probably going to have a huge influence on how efficient and effective these systems work. Cost efficiency and accessibility. Are we shooting for private companies developing software which cannot be used by everybody, which could lead to a two-tier system? Different populations using different software, having different chances in life or for their health. And standardization and personalization, that's going to be another thing about the benefits and risks. But also using these algorithms, i.e. algorithms, is going to have some implications. Are the companies or systems being forced to have transparent algorithms? That's going to be good for comprehension and trust. We're going to know what's going on. We could identify errors and correct it a lot faster, but also we're going to have large issues with intellectual property. We're going to see intellectual property breaches, and that there is no market economy which has an answer to that right now. If we look at big data with data collection, there are ethical issues. Are people going to be informed? Who's going to use that data? Is it going to be equally distributed? Who guarantees us as citizens or patients that we are asked to give informed consents? How are we going to deal with biases? If we regulate, we can correct these biases, but the ones who correct these biases within the data set, do they know exactly, or are they introducing new biases? So we're going to face the risk of slowing down the processes. We're going to face the risk of having insufficient data sources. And we're going to see the challenge of anonymizing this data. Stakeholder involvement, where I'm actually I'm promoting this as a huge part of value assessment. It's going to be comprehensive. We're going to have diverse viewpoints in assessment and the data, and we could ensure pragmatic and safeguarding regulations. But also, it's going to come to decision-making delay. We might have biases, and I'm not really sure if we can make sure that all of the parties involved would have an equal voice. So be critical of my personal viewpoints. What we need is a value equation, a transparent and structured formula on how to look at these new innovations. We need measures to either before they're implemented and after to evaluate these new technologies. And we need a systematic perspective incorporating different levels like patient level, system, provider level, etc. So that's something we have to work on and even internationally have the same perspective when evaluating these studies. So what I'm calling for is we have to assess beyond financials. We really have to look at the benefits and risks, not only look at the money which we have to invest. We have to be smart, make smart choices, always keeping in mind that we have type 1 and type 2 error. We need a guiding dialogue in society and expert panels and politics. It's not only about the cost benefit, it's more a strategic guide towards developing our healthcare system and our society as a whole, because that's a wide-reaching technology. Next steps, refine and implement these frameworks. And I know Katarzynę is already working on that. We are working on this in Germany. So hopefully there's going to be usable research to this. Thank you very much for listening.
Thank you very much, Axel. I hope you are still with us. I hope there will be a couple of more minutes in the end for Q&A, so just bear with me with questions unless there is any burning question for Axel to understand something from his presentation that needs clarification? I cannot see, I cannot hear, so I understand that we can move to the next speaker, and hopefully Axel will stay with us for if we'll have a couple of minutes in the end of our session for Q&A. This session is really to give us horizontal view of what is happening in different parts of the world. So I would like to bring us now to the north part of Europe, Finland. And actually it's even better because Finland came to us. So thank you very much, Jari, for coming that long from Oulu. Actually, it's a center of Finland, I heard today, although living in Turku myself for many years, I thought that I'm already in the north part of Finland, but no, there's Oulu. And in Oulu, we have a center of coordination for HT agency, Finnish HT agency, and actually Jari is senior planning officer there, working with digital solution, have been able to already assess 11 of the digital solution, many of them AI-driven. So he's coming not only with the Finnish experience, but a wealth of experience how to deal with digital solution implementation in the healthcare system. Jari, we are extremely happy to have you here. So if you could, in the next 10-15 minutes, shed a light for us how to do it, how to make sure that digital solution can be implemented in the healthcare system. What should we learn from your experience so far? Thank you very much.
Thank you very much. Do you remote control?
We need a remote controller.
Okay, nice to meet you again. My name is Jari Haverinen. As mentioned before, that I'm a senior planning officer from the Finnish Coordinator for Health Technology Assessment. I'm going to tell you about the HTA activities for AI solutions in Finland. As mentioned earlier today, that our assessment method was developed to cover a wide range of digital health technologies, and this is also applicable non-medical devices and medical devices as well. And in our assessment process, there are 5 key assessment domains, like cost effectiveness, safety, data security and protection, and usability, accessibility. And we have this kind of scoring system available for those. And also we have the other areas which we are covering our assessment process, and we are dedicated questions related to AI solutions in those products, which includes AI solutions. And we have this kind of scoring system in use for the final statement for the product, depending on those 5 key assessment domains. And we are publishing those assessments in our web pages, dighta.fi. Those are freely available to everyone from there in Finnish and both in English. So what are the key specific aspects for the AI solutions which we are typically covering? So our basic rule is that basically AI solutions also should follow the same principles as other digital healthcare technologies as well. So they must provide evidence-based benefit, be safe to use, and their impacts on patients and organizations need to be clarified. And if we are talking about digital health technologies, of course, products, data security and protection must also be ensured in all situations. And also, special attention should be paid on the usability and accessibility issues as well. So our assessment, we are going to be very practical in our assessment process, and because our role is to support healthcare decision makers. So first of all, we are asking the basic information about those products. So what exactly defined problem is going to be solved by the AI? Because typically the AI is targeted one specific use cases. And one important issue is that could the problem be solved without the AI solution? In some cases, it can be done. And what is the AI's role in the product? And what kind of AI models the product is based on? And what important issue is also that is the AI solution validated in the environment in which it will be used. And then we have to also interested that what are the data sources of these AI solutions. Have the access granted during training, validation, and testing of the AI models. And of course, has the data protection and data security requirements been followed during training, validation, and testing process? And how many features are required for an AI model in intended purpose? And what is very important is that are the data sources used in the training of the AI solution relevant to the final use case? For example, the age and gender composition of training groups comparable for the real user groups. And also it's important that can AI model operate those cases where the input data is incomplete or is noisy. And how much data a company has used to train and validate the AI model. And in some cases, the retraining is possible for the AI solutions. So how the company has ensured that what are the data sources for the retraining and how the companies ensure that the system is not trained with the irrelevant data. And basic information that how the algorithm was developed and who made it, and there is the algorithm depending on the operating third-party services. And this is very important that this decision-making process first does the AI solution change the care processes, and what are the roles of AI solution and human in the decision-making process? Because in Finland, the legislation says that the doctor is the final who make the decisions related to patient's treatment. And how much training the end user is needed for understanding the operation logic and limitation of the AI model. And how the rationale for the AI model's decision and the uncertainty associated with the decision be presented for the end user. But for example, what are the confidence in the interval in this certain AI solutions? Current situation is that at the moment no product whose main functionality has been AI has participated in our assessment process. In many cases, there are products which the AI solution improve the performance of the products participate in our process. I think that's very typical that there are some algorithm which improve the product performance which are already in the market. And this is one example of this Kaiku Health service for cancer patients. This is digital therapeutics solutions for the cancer patients. This is the medical devices. This as classified according to MDD. And this is what information we providing in our assessment for the public audience. So this product utilized machine learning based algorithms, and AI utilized symptom assessment entered by the end user. And in addition, the accuracy of prognosis can be improved by making the laboratory test results and information treatment measures accumulated based on information systems. And based on that, AI generates the personalized predictions. And if necessary, it can be sent alerts to operating organizations. The algorithm itself does not require any special actions from the staff to operate. Okay, thank you. That is shortly how we ask the AI solutions in Finland.
Wonderful. Thank you very much, Jari. I mean, this is really impressive to see that we can already use your experience and try to follow the path of the assessment of digital solution in the clinical settings, and hopefully we can learn as well how to implement them. Unless there are any questions for Jari at this stage, I would like to introduce next speaker for today. And as you see, we are just flying over Europe to make sure that we get the impression from different perspectives. And from north, I would like move us to south. It's like Eurovision, isn't it? Now I'm going to move us to the Catalonia. And actually, I would like to invite, unfortunately online, but wouldn't be better if we move to Barcelona for a moment, at least with our perspective and maybe virtual reality. So the next speaker comes from US, from Catalonia. Sorry, Carl, you're coming closer, so I thought that you already want to come to the stage. Joking. So I would like to connect us with Jose Iberas. Jose Iberas, I hope he can hear us. He's the president of the Center for Promotion and Development of Artificial Intelligence in the Catalonian healthcare system. Actually, he is the person responsible for the implementation of AI, not only in specific therapeutic area, not in a specific hospital setting, but in the region of Catalonia. There are many experiences that he will already has been a physician himself and running machine learning algorithm himself, running master program for doctors in artificial intelligence, but not only that. Now he is responsible and delegated by Catalonian government to making sure that AI is implemented fully within the healthcare system. So Jose, if you would be so kind and present a little bit from your Catalonian perspective and bring some sun to our lives, it would be wonderful. Thank you very much.
Thank you, Catherine. Thank you very much for your kind invitation. It's for me a pleasure to be here in this challenging event. And I would like to try to speak our environment. Well, in Catalonia, it's out of places all over the world. We have demand to solve some problems with the patients. On the other hand, we have possible solutions with people that work in research institutes and big centers and so on. And the other problem, you have a limitation in the budget and resources. So the idea of the Catalan government is try to unify all this in order to clarify what is the best method to make the prioritization of the technology in order to give the opportunity that the citizens reach this technology. I'm going to share the screen. Well, I'm going to speak then what's the idea of this program. In Catalonia, there is some context where there is a lot of technology, there is a lot of big hospitals, there are 8 million population, and the idea is how to organize all this. So, although they are like in the Western countries in Asia, we are working some years ago in artificial intelligence. The idea is to how to democratize or make that all these technologies reach to a whole population. We're going to speak then the context, the main axis of our strategy, the challenge, the support initiatives, and the secret of this core that is the observatory. Well, we have a problem with the fourth industrial revolution that includes cloud computing, the Internet of Things, work with massive data in real time, because all these have arrived to health, and sometimes the clinician mainly will know how to make the best approach. On the other hand, we have a problem of laws, because the European data space is a new law that's going to be approved under the Spanish government or the European Commission in this second semester. The other point is the AI Act, the new regulation of artificial intelligence. I want to recognize that if you work with patients, you are speaking about medical products. And the third point are the medical device regulation, the GDPR, and so on. So we have to define a single framework in order to work. Then, in this context, we have a demand of the population, one. Second, we have a lot of initiatives that we have to regulate. And three, we have to put in order in all this framework where we have to keep that all activity related to artificial intelligence take care of legal issues, ethical issues, and in this context, the government of Catalonia wants to identify the best solutions to put in the hands of the patient and to do use in the market. For this reason, we need evaluation committees, follow-up committees, and so on, and create some kind of organization to take control of this. And this is what we call the AI Catalonian program. Well, The context is clear. The ecosystem needs that facilitate the transfer of knowledge of technology to the healthcare system for the benefit of the patient. The second point is the data quality. If you don't have good data, you have nothing. The third point is the alignment with the health authorities, who should have the control of all the new technology if you want that reach to the patient, mainly because we have public system, private system, and the ecosystem goes toward the patient independently of his private or public. After the equity, this means that all the citizens should reach to this technology in the same manner. And finally, the efficiency. It have no sense to spend a lot of money in things that put value in the market. We are going to create a technology, but we need, the first point is don't forget the citizens. Second, the sustainability. Take care of the budget. And three, the main value that we should get a code transversal. Transparency, efficiency, innovation, commitment, participation, respect, and as I told you before, sustainability. Well, for work on this, we need to work in these main axes. The first one is research and innovation, second, evaluation, and third, implementation. For research and innovation, we need to identify what are the solutions that are appearing in our ecosystem. For this, what we have to do is to launch some AI challenges in order to be able to make a call to the whole ecosystem in order to have in our table the possibility to evaluate and prioritize all the technology. Second, if we identify the best one, we can give support with budget, with data, with engineering to this kind of solution. And three, the observatory. The observatory is the tool that gives us the opportunity to make all the roadmap, the evaluation, the follow-up, and after the implementation. Well, for the evaluation, we need committee for evaluation. After, we have to make monitorization, and after the integration of the tools with the system. Well, in this context, the main challenges depend on how clear the objective. Our main aim is to put all these systems in the market for benefit of the patient by the hands of the Minister of Health. The second is implementation of the solution by the systemic level, not only some part of the system. Three, try to use the incorporation of public procurement as a mechanism that guarantees the choice of the best tools. This is tenders. And after, the public instruments with the financiation of the European Commission. Well, this is how it works. Then the first point is we have to need the best solution for our citizens. Second, we have to make, once we recognize the main needs of the system, we have to check what we have in our system in order to prioritize if we can help them. If we have nothing and we discover in the market there is something like some solution for other countries that it works and we can buy it, why not we're going to do it and not lose time and money and create one. And three, when we have that, we have to take care of the budget and the resources to invest in this solution. I think we have to make the proposal of approval, working groups dependence of the technology, the procurement process. This means to create a tender, transparent in order to have the best solution, after the evaluation of the proposals and so on. And for all this part, we need committees, except committees for evaluation. This is the evaluation program of the health authorities in Catalonia. We need the program executive committee. In this program executive committee, there are the health system, the public system, the supercomputing centers, the ethical departments, and so on. After the technological committees, after the responsibility all the governmental healthcare system, and after any kind of work that we need to work in different specific aspects. Well, once we make the evaluation adjudication, then we have to make the deployment, the follow-up, and so on. Well, in this way, we have detected that we can work because we have a strategy that was to work in this program just now, just before the summer. But we have in our hands a lot. I will show you in the last slides. We have a lot of solutions that can work in the market. And then we have to make this prioritization. And we have realized that we have a demand in retinopathy, in radiographies, in dermatology, in drug interactions, and we have realized that we have this solution now appearing in our research institutes. Then why not to use them like a model to prioritize? Well, these support initiatives require two main issues that can be bottlenecks. The first one is to know very well the requirements to work in health. And these need to have protocol, guidelines, and so on, and follow all the ethical and regulatory requirements. And the second, never forget that we have to be updated constantly in how it works this. This means to have the idea that if you want to make the support, definition, and execution of the projects, you have to identify these projects, how are working in this moment, in the future, and have the follow-up of this project in order to be sure that if we want to become this project systemic, we are safe with them. Well, for this we have created the AI Observatory. The observatory has two missions. One, register all the AI tools that we have in the system and the different level of maturity. And second, the radar of all that happens in the European or in the world, on the world regarding artificial intelligence, and this means already with regulations, documentation, the dissemination of knowledge, anything that you have the opportunity to be updated artificial intelligence. Then it will offer. Yes. Yes. I said the last one presentation, the last slide. Well, here, do you want this presentation, this slide, please? In this slide? Well, then, for support these AI initiatives, we have to bear in mind that we have to go through two main issues. Identify the best projects to put in the ecosystem. Well, for this we have created the AI Observatory. The AI Observatory have two main missions. One, register all the AI tools in Catalonia and determine the different level of maturity in order to check what are the tools that need some kind of help regarding budget, engineering, data, or anything in order to progress with the process of maturity, with prioritization regarding with the budget. And second, we have to maintain the radar in order to be aware what are the last innovations in AI. This means regulations, this means ethics, this means with any kind of information that to reach to this world, the webinars, workshops, and so on. Well, this way with the AI Observatory, we have detected that we have just now 135 AI tools in our hands. Close half of them, 48, in research centers, 36 in healthcare centers, and rest in private companies. Of these are different level of maturity. So probably of these 135, close to 20% are in the last stage of maturity. This means that are close to the market. The maturity, never forget that doesn't mean nothing if you don't make the validation of the process with patients, like the evidence-based medicine when you put that out in the market. These are the other ones in different level of maturity. Here in the right you can see how much of them depend on hospitals, primary care, system rated with mental pathologies and so on. And the different specialties. The first one, oncology, after cardiology, primary care, gynecology, and so on. And this is amazing because usually until now, the FDA, for instance, have a lot of approvals, but mainly with radiology or mainly with cardiology, depending for electrocardiograms. It's difficult to find solutions, as I said, to clinical problems that depends not only on imaging. So, in summary, our aim is try to democratize the AI to reach the citizens, and for this we have to know first the needs. Second, what do we have in our environment in order to help them to reach to the patient, and why not to the market. And three, try to get the sustainability, the equality, and always following the legal and regulatory issues depending on our environment, that is the European Commission. Well, thank you very much for your kind attention, and why not, probably this is an important point to keep going in the discussion.
Thank you very much. I'm really sorry for the quality of this of the sound. I mean, this is sometimes challenging, especially when the technical issues arise and are not tested previously. So this is the learning to test the technical connection in advance. But thank you very much, Jose, for joining us. It was a great pleasure to have you with us, and I hope that we will be able to return to Catalonian experience very soon, to understand how we can benefit from it. What I like most, and what potentially you have not seen on the slides, but the slides will be available later, is the different maturity levels that Catalonian system define AI implementability in the system. So I think this is something that we should learn how to ensure that we measure maturity of AI technology before we allow it to be implemented in the healthcare system. 9 levels have been established in Catalonia, and only 1/3 of those that are in use have the highest maturity level. Others are under provision. Very interesting concept, something to learn in such country like Poland, I believe. Last but not the least, I would like to invite you to US. So, coming from different European settings, fortunate for us, Karl decided to come directly. So, Professor Karl Asch is Executive Director of Outcome Research and Pharmacotherapy from University in Salt Lake City, University of Utah. So, thank you very much, Karl, for coming so long way, especially for this event, and being with us in person to shed a little bit light how US is accelerating, because there is no other proper word, and how come that US managed to get so fast in AI adoption. More than 500 AI technologies are already reviewed and approved by FDA. So the question is what we can learn from this fantastic experience. The floor is yours. Thank you very much, Karl, for coming here.
Thanks very much, Katarzynę. I appreciate the invitation and the opportunity to speak before you. I did so yesterday in today's much more abbreviated form. So introductions aside, I'm Karl Asch. Pleasure to see all of you and those of you online. In a brief 10 minutes, I'll attempt to relay to you what the FDA, the Food and Drug Administration, tells us. They guide pharmaceuticals, medical devices, AI, digital health interventions. They're in charge. Their mandate is to ensure patient access to a safe and effective medical devices. And they've had numerous stakeholder groups over the years. They put so much work, so many guidance documents are out there. All the algorithms associated with the technologies are archived, available. The algorithms themselves are not available to look at, but the gist of what they are available online. Over 500 enabled medical devices through AI are already cleared. There's an Excel spreadsheet in the presentation, which you're more than welcome to obtain from the organizers, which lists all the technologies cleared and approved so far. It's mind-boggling. I'll talk a bit about the opportunities that the FDA sees ahead of themselves. They're just keeping up, in my opinion. There's just so much going on. The challenges, they actually have a framework approach for how they're going to manage the workflow, because they anticipate a lot more technology to review. And then I'll just briefly touch upon their recent meeting whereby they provided an indication of their actions and their future goals. They did a really good job of defining artificial intelligence, machine learning, and machine learning-enabled medical devices. I find this very important, whether it be in digital health or any other area, to have the definitions in mind as to what we're talking about. That being said, as I mentioned, there's over 500 machine language-enabled medical devices already approved by the FDA. Here's just a few. Stemming back to during COVID, or around COVID, caption guidance was the first cardiac ultrasound software that used AI that was approved by the FDA. GI Genius was the first device that used AI to help detect potential signs of colon cancer. Page Prostate is another piece of software that helped identify prostate cancer. Cancer detection is a big deal in terms of AI-enabled software. It's also a big deal in terms of looking at the risk of a patient within the hospital setting to acquiring sepsis. There's high mortality associated with sepsis, so if you know the risk associated with the patient, perhaps you can treat them sooner. That being said, the opportunities within the space of enabled medical devices, There's not that many to speak to right now, other than there's a positive impact for all of us because there's an opportunity for earlier disease detection and therefore treatment, a more accurate diagnosis, new insights into human physiology that we may not have known before, and this all speaks to personalized diagnostics and therapeutics. It applies across all the medical specialties, not just radiology, which is where software is used to help detect cancer better. It's used everywhere now. And we have the ability now to not only learn, adapt, but also improve the performance because this software is constantly getting upgraded, just like the software on your phone and your computers. This is constantly evolving. That being said, the challenges, according to the FDA advisory panels, well, diversity is important. So a fit-for-purpose data set needs to be developed and tested accordingly. They have to somehow remove or minimize bias and as well as the identification. The opacity of some algorithms has to be dealt with. The FDA is providing oversight for an adaptive system, and they want to ensure transparency to users. They have a life cycle approach, which is here, and it's quite relatively easy to follow. You'll see by the different color codes here, one applies to the model development, one applies to the actual AI production model, AI disease modifications, the manner in which they loop back, and of course the proposed approach that they're taking. So they have a pretty good roadmap ahead of them too. They have all kinds of stakeholder meetings coming up, and I'll just speak to that in terms of their future directions. I hope that's not my phone. The issuance of draft guidance on the predetermined change control plan. In the last 2 years, they've had 3 guidance documents published, so they're constantly evolving. They serve to participate in collaborative communities and have consensus standard development efforts, including stakeholders such as patients. They've had thousands of patients interviewed as part of their process. They make a point of having public workshops in terms of medical imaging, or sorry, medical device labeling to help support the transparency to the users who are using these particular devices. Once again, they're working towards removing or eliminating bias, and as important as anything else, and this is a subject which is important to this meeting, clarity as to what type of real-world evidence should be offered for AI, ML-enabled devices. Should we go the route of pharmaceuticals and have RCTs? They're expensive and time-consuming. With the rapid pickup of the 500 plus AI/ML-enabled devices, you wonder how many of them actually had compelling evidence to help show their safety and their effectiveness. My guess is very few because of the costs associated with it. That's my 10 minutes. I'm happy to take questions since I'm here live and in person. Would anybody care to? I'm just going by all the documentation that the FDA has released. These are not my own opinions. So you got to be careful when I answer questions. I may not know the answer. And no questions is probably a good way to go too, by the way. Oh, Katarzynä's up. Okay.
Actually, for those who don't know, we had the opportunity to have a roundtable discussion with some representative from Polish Ministry of Health, National Health Fund, and the head of the Polish HT agency. It was pretty informative, but I kind of sense that there is some different approaches from you as well from the Polish side regarding how to implement AI-driven health technologies into the clinical settings. And whether you can elaborate a little bit further, what would you do if you were Polish Prime Minister or Polish Ministry of Health? So starting from scratch and say that now you have 500 AI-driven technologies and now you need to implement them in clinical practice. You both are knowledgeable of HTA, health economics. How are you making sure that you select the ones that should be reimbursed? What kind of data, evidence you would request from them to making sure that that it is really applicable? And actually, I'm so happy to hear that we have both our German and Catalonian friends with us. So the question I would like to ask each of you, but not from your country perspective, but think about yourself and put yourself into the Polish context. And what would you do if you were Polish Ministry of Health / Prime Minister, and making sure that the criteria setting has to be developed from scratch? Shall I start with you, Karl? Because I see that, can sense that you have more experience from a US perspective. Thank you.
I work a lot with guidelines for the past few years, and which mic? This mic? I believe in guidelines. We're all members of associations which create guidelines. They have special interest groups, task forces, and whatnot. In the health economics world, we have consolidated health economics guidelines for pharmaceuticals, perhaps for digital health in the near future. There's already work starting in the AI space for guidelines on how to do this. The key is transparency, and having some type of universal evaluation criteria. I think that applies to Poland.
Okay, but what kind of criteria would you select if you have to choose three?
Okay. Well, use of real-world evidence. Gather the evidence like we do for our pharmaceuticals and I'm going to say medical devices, so why not AI? You want three? Okay.
Yes.
We have learned from our pharmaceutical work and other health technology work, we have already guidelines in place, value-based frameworks, much what Axel's doing in Germany. No one's reinventing the wheel here necessarily, but I know there's a lot of work being done by Axel, so I'll leave that to him to explain. Well, transparency is just as important from the perspective of a payer. These are very expensive products.
Wonderful. Okay, we have three. So this real use of real-world evidence, principle number one. Principle number two, value framework. And the third is transparency. Yeah. Thank you very much. If I may jump into the Axel, since your idea of value framework has been already piggybacked by Karl, so it's already exported to US. What would you say if you were the Polish Minister of Health? How would you adopt the values framework for the assessment of AI-driven technologies?
Karl's a very nice person. Because we learned everything we know from the US, and Karl's perfectly aware of this. So the value assessment framework and the logic behind that was mainly driven by the FDA and the associated offices. But coming back to the question, we got standards: cost, benefit, and risk. These are the three dimensions. If it comes down to cost, direct, indirect, intangible cost. Here we go. We got to frame the resources needed. Benefit gets a little bit more tricky. We have to look at clinical and non-clinical benefits. Benefits within the organizations, benefits for the patients, because that addresses the issue of who's going to pay for it. And we need for the maximum acceptable risk and the willingness to pay or cost benefit thresholds, we need a one-dimensional number explaining the risk, which is the net benefit. Net benefit is the benefits minus the harms. And then we have to separate these both, to get more glimpse of uncertainty, which would be the fourth dimension. A lot of information is uncertain. Seldom we got full information to make these decisions. And these are the brackets and the dimensions we need. And we need the frameworks to systematically use these guidelines. And that was perfectly explained by Karl. to climb up the ladder and get more and more information, to make more and more informed decisions. We should not do this piece by piece, and for all of these technology extra separate, it has to be done in a coherent, transparent, systematic way.
Wonderful. Thank you very much. So now we have 3 principles, 3 criteria to be measured: cost, benefits, risk, and net benefit ratio. Finally, fantastic. So, Jose, you are not only health economist, AI expert, but you are also clinical expert working with patients on a daily basis. So how would you, from your different hats you have on your head and many experiences, what would you say if you were now moved to Poland and became the Minister of Health? How would you implement the system for the evaluation of AI technologies? Thank you.
Well, I only have something from a pragmatic point of view, and to tell you with the previous colleagues in transparency, the cost benefits in order to all the cities can access well to these kind of solutions. But I think probably what comes is the access data. We are not going to be able to implement AI solutions if the data are completely separated in different places, in different kind of software, different hospitals. And this sometimes is a limitation in order to work with imaging, with electronic health records, and so on. So probably, I think, mainly for public health systems, and this is the main problem of the private systems, when you have not tools that you can put everywhere, and you can even have the benefit to obtain with a lot of data. We have a problem in Europe with the main societies. We have to send a registry of our data of different specialties to a common data work, and the data are completely different, are differently storage, with different values, with different characteristics that mean that we can use it. So I think probably that one of the main aspects is that any solution can be implemented everywhere. Then the government have the responsibility to try to identify the criteria to access the data in order to implement the solutions. If we work with retinopathy, we work with cancer, we work with analytics, these kind of solutions, if you have a regulation that makes any kind of solution use a standard of data, probably going to be easier to put this kind of tools in private and public parties. This is one. The other point probably is related with how to make easier to use this kind of tool, the balance, the privacy, GDPR, and so on, and the benefits for the patient. There are important differences between the United States and Europe, regarding the access to the information, how to manage it. It's difficult to find this question, but probably the future is in time that the patient always have the right of defend the privacy or the rights of their data, but on the other hand, facilitate the investigation for all the public and private groups in order to try to increase the possibility of create best tools. And sometimes we are too strict with this kind of rules, and sometimes you are so. I don't know how, I have no answer now, but we have to work probably to facilitate the research in this sense, because this goes very quick, and if you see how it works the industry in comparison with medicine, probably we are going to have possibility to be quicker. This is probably the main two aspects.
Thank you very much. So the data is definitely crucial, and that's the denominator for all of our discussion of criteria and principles. And Jari, I know that you have not only vision, but you have experience with an evaluation of digital solutions. So what would you do if you had to start from scratch in a different country?
I first think that what are the claimed benefits for this certain product? That how can be those benefits can be proven and measured? I think that this is one key issue. And as mentioned, Jose says that access to data is very important. The interoperability is also very important, and also the quality of data, which kind of data we have available for the certain product. And as our experience is that I say that the cybersecurity is also very important in case for digital health overall, and especially for the AI solution as well.
Wonderful. I think that's important, especially we know that there are some examples from Finland from the past of this data security and privacy breach. So that's something that we should learn as well, not only positive examples, but those that gave us understanding of how corrupt they can be and how important is interoperability, how we can measure the benefits, what you said yourself, Carl, and I would like to come back to this, what you said, the first thing, which is real-world evidence. If we don't have interoperability in the system, we cannot measure the real-life outcomes. So what is your perspective, how we can learn from the evaluation of pharmaceuticals and bring this to digital solution from the standpoint of real-world evidence? What will be the key learnings for those who are developing the digital solution? What you would tell them, guys, you need to collect the evidence, but how?
Yeah, that's a multi-million-dollar question because of the expense, the time associated with RCTs. A small startup company we discussed earlier this morning are not aware of the costs associated with trials and so on. So they're not thinking this through. In terms of the health economics and outcomes research, that's a secondary outcome in a trial. It's important to measure. And there's the, and there's the time. You have an innovative product with AI, machine-enabled device, and you have to spend how many years to get a trial to help prove its effectiveness, efficacy, and safety, and technology moves so quickly. I think my point is, I don't think they're going to be doing this.
Jari, any comments from you? If they were not going to do this, how we will get reimbursement?
Excuse me.
If we don't collect real-world data, how we will ensure that we have reimbursement for digital solution?
I think it always not requiring the real-world data, but really helps. I think the digital solutions collect almost automatically data in electronic format. We don't have to use paper questionnaires and things like that. I think it's very easy to collect. For example, the prom measures from the patients.
Exactly. Yeah. So we tend to forget that digital solutions are doing digital work, digital intervention, but they do collect data as well. So this is by default easier for them to understand what is the value if they start collecting the data and analyzing the data. So thinking about, Axel, your idea of your concept of the value framework that it's so nicely presented in your slides, where do you think we should get the data from about the benefits and how we should measure benefits? It's only clinical value, which normally has been the case for Germany, but now with DIGA there is more into the efficiency gains as well. So how do we define the value from the standpoint of the digital solution being not only used by patients but sometimes by doctors? So what are the outcomes? What are the benefits in your opinion?
Yeah, it's a good and tough question. And the easy way to answer this is to move a little forward in time. That's a little app I have on my iPhone, and that's how I can contact my doctor. It's a starting point to get treatment via my mobile device. So let's say this is going to move forward in 5 years. We have multiple data on these touch points in a patient journey, and that data can be collected. There are issues of privacy and there are issues of ethics, but putting them aside, we're going to face the same reality like, for example, Amazon or Google has right now. And there are multiple chances to do A/B testing within these data sets, within these touch points with patients. And then let's transfer this world to the hospital. incorporating the hospitals and doctor visits into that world where we have sufficient data and produce and have the chance to collect huge data sources. And I don't want to downplay the question saying it's easy, but I think there's light at the end of the tunnel because technology is going to change. And we're going to have the possibility, what we call in healthcare, clinical trials, randomized controlled trials. In IT, they're called A/B testing, with control groups. And we can have these small, quick interventions looking at how things change if we change different variables. So once again, I don't want to sound too smart. I don't want to downplay the problem we're having right now with real world data, but that technology is going to shift everything into a new world if we have the chance to let this shift go, so that we're going to face new chances.
I think we need to mute one of the speakers, if I may ask IT to help. Thank you. Thank you very much, Axel. That's really important because it means that we can adopt a little bit more holistic view on the healthcare system and not look through the clinical benefits what we used to think so far. But that brings another difficulties for us health economists: how we measure value if we are not focusing only on clinical benefits. What would you do, Carl? And I know that you are going to be in the panel for assessment of digital health solutions. So what kind of framework you are going to adopt for measuring non-clinical benefits if it's not something that can be translated directly into clinical value?
Well, at the risk of, I'm not going to try to sound smart here, but it is important to define those with higher risk. To me, that's an aspect of a clinical trial I haven't really thought in the future as much as Axel has and others. And I still look at the painstaking process of trials as we know them now. I believe safety concerns and efficacy are as important as ever. The economic story is pretty straightforward if you're if there's a survival benefit or something to that effect. Like I said, I'm not going to try to sound too smart about this. I'll pass the torch.
Yes, I think it may be economic or healthcare burden, service burden point of view, because I think in Finland we have one target for the digitalization is that the healthcare burden can be decreased, so that people, so some kind of self-help online services. So our target is somehow keep the people away from the hospitals. If you can support the self-care services or some kind of intelligent chatbots and things like that. Yeah. Mm-hmm. So I think that way we can reduce the burden to the healthcare itself. Yeah. Mm-hmm.
Very interesting. So this is exactly what Axel has mentioned with the remote treatment. So we are moving into virtual from physical environment, which not only brings us quality of time, but also the efficiency gains, if I hear you correctly. Wonderful. So the final question, because I know we talked about it, and I think something that is really important to learn as well here in the Polish setting is how we compare, because normally we need to understand the value not only in absolute, but if I may sound a little bit to university teacher, but incremental terms. So what is the added value? So I know you talked nicely about how you understand digital solution in terms of the comparison with standard of care. How you make the judgment, what is the standard of care if there is a new fancy mobile application for the treatment of diabetic patient. So what is the standard of care if something like that didn't exist in the past? How do you in Finland say, please use this as a standard of care?
I think it depends. That it can be no care at all, the comparator. I think that there can be that no care is the standard of care because we have the new system which we are using. Or we have the traditional way to perform, for example, the mental health treatment, and these new mental health apps. But I have so clear answer that what it is case by case that we have to evaluate that. Is this totally new way of thinking about the healthcare, or is it somehow comparable to existing ones?
Okay.
Yeah.
So final question, Axel, to you. Do you see the future that we will have digital therapeutics or digital solution, and then I will ask Jose as well for the final comment, replacing pharmaceuticals? Is it the future like that?
I don't know. I think the chances we're seeing with digital applications are going to open up a new dimension, which means they're going to be something new within these processes. Exactly. of providing care to patients. So pharmaceuticals is going to be a part of this process, but with technologies, we might stop overuse. With technologies, we might stop underuse. So it's not a parallel process, but it's certainly not in competition with pharmaceuticals. I think it's another mosaic in a large chain, which we could call the patient journey, which has multiple touch points, and these touch points aren't working. For example, with pharmaceuticals, which are overused, or too many pharmaceuticals being used. And technology certainly helps to get this in line with what we call the practice guidelines or clinical guidelines.
Wonderful.
I hope I did answer a little bit of your question.
Exactly. This was my point, just to be more provocative to get this answer. Thank you very much. Jose, what do you think? How would you see?
I believe that AI, and mainly generative AI, is probably going to become one of the because you have to avoid a lot of morning trials. It's surprised how good the AI is able to different consider target for different. Only we don't know where to go. This go very good, and the capacity of this kind of not the classic machine learning, but generative machine learning is able to carry the speed of with drugs. The digital twins only try to be having our environment first, second, third. How do you expect that the result of that you create being human being probably is an important part of the future that going to be able to follow up us. The problem of this really is that we have a lot of bias here. We have an area to interpret what's happening, but we are now in the stage. You go to the medicine or to check the you artificial intelligence. There is thousands and thousands of articles. You go to the DVD approved 3 or 4 years ago, 100 or 200, 200. So this was very, but the problem is the goes to innovation, and after that we speak a lot about how to validate what's happening with the patient.
Okay.
And this aspect, like to take if you will allow me, that the big problem that we have the clinician, the lack of training and started with the grade, the graduate, and in the special. The clinicians have a full opportunities to glean artificial intelligence, and the problem is that the mobility between engineers or assessing rate should be assessed in such a way that should be shared. The problem aspect it was very engineering very quickly. Yes.
Thank you. We have a really bad connection with you. I mean, that's really, we heard a couple of words, but I'm afraid that we need to stop you here because the connectivity is not good enough for us to, especially when I'm looking at the audience, to listen. I will try to repeat what you just said and trying to link the words I heard. And thank you very much for your contribution. Jose talked about digital twins as well as not being sure about this connectivity between having the digital solution replacing pharmaceuticals. I did ask this question with attempted provocation, intended provocation, I should also say, because I think that there's more that is discussed here and should be discussed in the future, is something that how we can use digital solution for the benefits of optimization of the pharmaceutical treatment. And one thing that is definitely, there are already examples, how to use virtual reality for the patient, for the pain management. So there are a lot of opportunities there, and I think this is what I would like to leave us with, looking into the future, not only from the standpoint of, yes, let's implement AI into healthcare to speed up, to produce more clinical benefit, but how to integrate AI with other treatment modalities and making sure that those different treatment modalities are used now more effectively thanks to AI-driven technologies that not only produce the effect, but collect the data. And with this sentence, I hope everybody agrees. And I would like to so much thank all of you, especially Yari coming from Ula, you, Cal, coming from the South City. I'm sorry, come on, I would prefer much better to stay over weekend there, but you chose to come to Poland to Warsaw. Thank you very much, Axel and Jose, for joining. It was such a great pleasure to have you online. Hopefully next time you will be here as well. Yes, we can hear you. We can see you. Thank you very much for your enthusiasm, and let's connect again soon.